Happy Friday. This is Ray Pedden from the Center for Care Innovation. Welcome to CCI's Raven e-learning series. The Raven e-learning series has been developed to highlight technology solutions that address priority areas that have been identified by the safety net provider community. Raven has been developed as a CCI learning laboratory for the safety net. To join Raven and take advantage of all the platform has to offer, please visit raven.careinnovations.org. You can see the future topics in our series at raven.careinnovations.org /e-learning/. In support of what we're going to do today, which is talk about telehealth and medically assisted treatment programs, CHCF has just published an innovation landscape around telehealth and MAT. And I want everybody to be aware of that, and I will be sending the link to this landscape over the chat function so you can pick that up at your leisure. Well, let's get on with our program today. What we're focused on today is telehealth, a delivery model for medication-assisted treatment. What we hopefully will walk away with today is why you should consider using telehealth in a MAT program, how to set up the operational processes to meet the needs of the provider, the support staff, and the patient, and what do the patients think about this type of treatment modality. Today's faculty include Dr. Daniel Pierce from Borrego Community Health Foundation and Ellie Hamideh, the VP of Integrated Services at Borrego Health. I'd like to turn it over to our distinguished faculty. Please welcome both of them. Daniel, Ellie, if you want to unmute yourself, I think then we'll all be able to hear you.
So Ellie's going to start.
Let me find her. I'll unmute her.
Can you guys hear me okay?
You're perfect. Thank you, Ellie.
Awesome, awesome. I was talking and I'm like, I don't think they can hear me. Good afternoon, everyone. So I work very closely with Dr. Pierce, and we're here, like Ray said, to present to you on medication-assisted treatment and delivering medication-assisted treatment through telehealth. So Ray, please, if you can move forward to the next slide. And we can probably move right on to the next one. Great, thank you. So like Ray said, our agenda today is really to kind of get folks thinking outside of the box. We initially started off the MAT program only in person, and then we started to realize that it was creating barriers for our patients on access, and so we moved forward with trying to do all of our follow-up visits by telehealth. We can move on to the next slide, please. And the next one, please. Great, thank you. So for those of you who are not familiar, medication-assisted treatment is really defined by SAMHSA as using medications in combination with behavioral therapies to treat substance use disorder. So here at Borrego, we are treating opioid use disorder with Suboxone or buprenorphine. And that is what we're considering our MAT program in combination with our psychotherapy. We can move on, thank you. So kind of the big question we get is, why would we even think about using telehealth as a delivery model? And so it's common telehealth delivery model access. It creates increased access for our patients. There is a limited number of ex-waivered providers. So Dr. Pierce is one of the few providers in our organization who was willing to get the ex-waiver and treat patients with opioid use disorder. And so we can kind of take those handful of providers that we have and spread access amongst all of our clinics so that we can treat patients who are in rural areas that otherwise wouldn't have had that access. It also decreases the patient's travel time and decreases their wait time. They may have had to go into inpatient care or had to drive 2-3 hours to get this care somewhere else. And so telehealth really helps the patients in that format. So if you, and I don't know that we would call them best practices, but some learning points that we have that we considered our best practices, it was really important for us to have a provider champion. So from my perspective, I'm operational, and it's really nice to have someone like Dr. Pierce, who's a provider who can kind of act as that champion and mentor all the providers who might be worried about the stigma or concerned about the delivery model. So a provider champion was really key, not only in launching the telehealth component, but in launching the MAP program overall. Training was something we learned about. Not only do the providers need training, but the entire clinic really. And so whether that be telehealth modality or in person, training for the providers, our back office staff, and our front office staff was actually really important. On an induction day, the patient comes in with withdrawal symptoms, and not everyone knows what that looks like, knows what to expect. They might be afraid. We want to make sure they are aware that the patient might be very uncomfortable, might be wanting to go wait outside for a few moments in time. So just giving the staff kind of an in-service and letting them know, hey, this is what patients in withdrawal might be experiencing, was a really big learning point for us. And then third, we have team-based care. And so care management and having something we call a systematic case review was really important. Those systematic case reviews can be done over the phone, they can be done with telehealth, but it really is a chance for our providers to connect with each other, discuss the patient's case beforehand, talk about what that treatment plan is going to look like, what concerns the psychologist might have, what concerns the primary care provider might have, and they can kind of look at it from a group perspective and come up with the best plan to discuss with the patient. And then we do have behavioral health services in-house. We can do, some clinics have a psychologist or an LCSW at the clinic, and so those behavioral therapies are provided in person, and some of our clinics, the behavioral therapies are provided via telehealth as well. We are really fortunate in our organization that with pharmacy support, we actually have in-house pharmacy, but we've had certain clinics where we collaborate with pharmacies nearby in order to get the medication delivered to the clinic or delivered to the patient, just so that we can try to exclude all barriers for the pharmacy and the patient. And then finally, I think the biggest thing that we learned was to start slow. So we were fortunate enough when we started off with the MAP program, we had a practice coach with us from Northern California who'd been doing this for a few years in primary care. And he told us, just start slow. Don't pick a patient that you feel uncomfortable with to begin with. Your first patient should be someone that you feel very comfortable with. Kind of start with the easiest process possible. And that helps to prepare us and our team and our staff for what might come in the future with the more complex cases. And so starting slow, starting with 1 or 2 patients, blocking a half of a day with your provider for their first induction, and just kind of providing any support needed for the team to feel like this is not a scary process. It's something that we can do, and we have the patience and the time to complete it in. So a lot of questions that I get operationally surround telehealth and billing, the codes and the modifiers. Something that was important for me was something I actually got some pushback from our administration on, can't the providers just pick the modifier? Are you telling me that the providers can't just pick the T code and add the right modifier? It's part of their role as a provider. And for me, it seemed to overcomplicate things. And so this is not only specific to medication-assisted treatment, but any treatment that you're going to provide telehealth. It seems silly that we couldn't figure out on our administrative end how to make this easier for the providers. So what we did is spend some time with our billing department and our EHR department, and we figured out a way so the provider sees a very simple super bill. They just choose the normal code they would choose any day, but it has a T at the end of it, and in the description it says telehealth. This way, the provider is able to indicate that they had a telehealth visit, and all of the modifiers and coding happens on the back end. The provider doesn't need to worry about anything other than providing the care to the patient and choosing the normal billing code that they would have otherwise chosen. And so I think I talked a little bit about this, but how we got started in the MAT program is that either patients were self-referred or their primary care provider referred them. They were established with their PCP. We just did a tracking code in-house so we could kind of figure out which patients needed the MAT program and which didn't. The providers would have a consultation for the MAT program, and that was primarily done telehealth, again, because our MAT providers are spread thin and spread in different regions, and so the consultations were typically telehealth. The induction is always done in person. So the induction, the provider would actually travel to the location of the patient. We would block a morning or a whole day so that they could get the induction done, and then all of the follow-up was done telehealth. And we would have systematic case reviews, and then everything else was done telehealth for that patient unless we needed to go back in person and they would see their primary care provider if any complications occurred in between sessions. So I think I talked a lot about this slide already. We can probably skip forward. And this slide, this is one of my favorite graphics, and it's a few years old. I'm sure many of you have seen it, but it seems silly that in healthcare, we kind of treat the mind and the body separately. And so MAT, for me, is one of those programs that really shows true integration. And telehealth with MAT in particular kind of forces that integration. So some of these services and these patients would have had to go outside of Borrego to seek treatment, whether it be inpatient or whether they were driving a couple hours, or if they were, for example, in a methadone clinic. And so we wouldn't have that chart information available to us right away. We wouldn't have the collaboration that we do when it's our providers in-house and they can just pick up the phone, call each other, talk about what's going on with the patient, talk to the psychologist who's right next door to them, and really provide that like true whole person healthcare. So for me, it's the biggest selling point for the providers is you're really going to know what's going on with your patient when we keep them in-house, when we do it telehealth, when you have information in your chart, in your same EMR system that you're already using, and you can access that patient right away. And it also encourages the patient themselves. Some of these patients that we have had conversations with never wanting to go outside to get treatment, but because they knew it was at their home clinic, and they were much more willing and accepting of using telehealth to get the treatment because they would prefer to stay with their doctors, with their home clinic, the nurses and the medical assistants that they know, rather than going outside and kind of being worried about what stigma they were going to be encountering in an outside facility versus somewhere that they've already been coming for years, and just meeting a new provider, you know, once in person and then all those follow-ups via telehealth. So Dr. Pierce, I'll turn this over to you.
All right, if I could just make a couple extra points. We have the medication delivered to our clinics or wherever the patient is going to be at so that we can hand it out, and that seems to ensure adherence to the visits, because if we just give a patient 90 or 60 tablets, they may not show up for quite a while. Let's see, we also get referrals from word of mouth and also from parole officers. And let's see how much time. Okay, so let's talk about this patient. For instance, a 34-year-old male who was requesting a Suboxone refill, but the patient has a history of heroin use on and off for several years. The patient has received outpatient treatment with Suboxone, but could not get a refill and started taking heroin again when he ran out. The patient is motivated to stay on Suboxone. He states that he has a wife and kids and doesn't want to put them through that again. So the patient accepts referral to psychology as part of the medically assisted treatment. We make it mandatory that the patient is offered it. We don't force them to go see these psychologists, but we know that they have many issues besides just a heroin addiction. Next slide, please. So the process that we've been using, first we meet with them. They may be in one of several clinics away from the clinic where I'm at. I'm only at 3 clinics out of the 26 clinics or so that Borrego has. And so we talk about the induction process and set expectations. And then I order the medication to arrive at the clinic where I'm going to induce them, one of my clinics. And we also schedule the clinic where the patient is going to be at for telehealth. And in the future, we would schedule the patient at their telehealth clinic and the clinic where I'm at, because both need to give us a room. but that's not the induction. So the induction, the patient meets me at the clinic, or I meet them at the clinic, and we sign consents. They have a physical exam, and we give them the first dose of Suboxone depending on how much withdrawal they have based upon a COWS scale, clinical opiate withdrawal scale. And also how long ago they seem to have used their opioid. And we don't want, the main problem with this is not to cause severe withdrawal. So I start out sometimes with just 2 milligrams and watch them 15, 20 minutes later, then I give the second 2 milligrams. And this has worked very well. I've had nobody with bad withdrawal except somebody who was probably not telling me the truth and didn't really have the withdrawal. They said they had the symptoms on the COWS scale, but I wasn't seeing much there. So the next time I started with 2s on those type of people, and it works very well. Then we have follow-up. And 2 to 5 days later, we talk about how it's going, how many they're taking, how often, what are they feeling, what about withdrawal, and adjust the dose as needed. And then I see them a week later, then 2, then 3, then 4. And I may have to go back to a shorter interval if they're having problems or adherence problems. We do a drug screen, of course, to see if they're on the Suboxone. And then once a month, we have a multidisciplinary team or case management conference, and I join by phone to one of the sites that seems to have a large number of these patients. Next slide. Well, just before this slide, I should mention that on telehealth, that the medical assistant or the nurse putting the patient in the room needs to really be the eyes and ears and feelers for the provider on the other end. So the assistant might say, well, the patient has a new limp, the patient seems more irritable today, the patient smells of alcohol, here are the PHQ-9 depression results, and the blood pressure is high, just to remind me. So we need a little more active input by the medical assistant who's actually seeing the patient physically. Go ahead, Ellie.
Great, thank you, Dr. Pierce. So I think that the case that Dr. Pierce presented, 34-year-old male, very motivated, accepts the referral like we said. He's been on heroin. He's motivated by his family and himself to kind of get the treatment. And so what's the problem, right? This is something that unfortunately in healthcare, our patients come across are these roadblocks. So personally, I think for everyone on the call, probably when you come across those roadblocks, you get frustrated. You might just say, forget it, I'm not doing this anymore. And you might not be motivated to continue. So the roadblock for that particular patient would have been that he lived in Coachella Valley, and we do not have a medication-assisted treatment ex-levered provider in the Coachella Valley. And so our closest provider is about an hour and a half away. The closest inpatient treatment, I think, for the patient was probably at least an hour away. And so that patient could have just stopped the motivation and just said, forget it. There's too many roadblocks to get this treatment. I'm just going to keep on going with this heroin treatment. What telehealth did for this patient is it created that access. It gave an open door for that patient to receive his treatment continuously in the Coachella Valley. So we can move on to the next slide. And I want to read to you this letter, and this is actually a letter that the patient we're talking about wrote to the staff, and I cut a piece of it out, but he wrote it to the staff, and he says, I am on my 4th week of taking Suboxone, and I am so proud to state that my life has done a 180. When I first started, I was a mess, someone who hated themselves and lived depressed every day. But now, I love who I'm becoming. I feel like my future is promising. I have mended old relationships, stopped being depressed, and found I enjoy being sober from heroin. Today, I have a job that pays me well and people in my life that care about me and want me to succeed. Thank you to everyone. And so I wanted to read that letter to you guys because I think it's really, I think I want to pull at your heartstrings a bit, but it's really important to realize that just that one telehealth visit in the Coachella Valley changed someone's life. And that person was so thankful that it probed them to write a letter, and he's continuing to get this treatment from our providers telehealth. He would have never been able to have that treatment otherwise. And so I really wanted to just know a very specific case. These are the types of patients that come into our doors every single day. And so telehealth is really a way for us to get them that treatment without necessarily overburdening and, you know, having a provider drive every week to a certain clinic. We all have those productivity limitations that we have. And so it's sort of meeting in the middle and creating that best access in the most efficient way possible.
And so I was talking to my patients about the benefits of telehealth, and with the MAP program, it starts the healing and maturity process finally in their life. They may be 30 or 40 or 50 years old by the time they start down the path of maturing. And the telehealth helps people to access us when they have chaotic lifestyles. For instance, yesterday a patient was erroneously scheduled for a clinic I was not at. So we connected with him by telehealth when I was at a different clinic. So it saved the visit and helped the patient be monitored in a timely fashion. For instance, if the patient was on methadone and Suboxone is thought of as a substitute for methadone, we don't do methadone on telehealth because they have to go to these special methadone clinics in California. There's left on Suboxone and on telehealth, there's less life disruptions. For instance, the methadone clinic is 3 days a week, but some people have told me they can graduate to once a month for the methadone, but very few do. And because eventually they'll be seeing us once a month. And there's less chance of overdose and death with a Suboxone. And they seem more employable because we also have more extended hours access through telehealth. I work till 7 or 8 on Mondays, and that's where we can see the workers. So that works better for them. The patient can be a better parent, daughter, son, or spouse because they're engaged, they're more alert, they're more mature. They can be a better employee, student, and patient with physical and mental issues, but they can start addressing those better rather than masking them and letting them get worse through ignoring them. And a number of patients have told me they seem sharper off either their Norcos, their heroin, or even their methadone. Their mind just seems to work better. So I'm really excited about using the MAP program and helping these people get on with their lives. You're doing them a great favor, even if they're off their opioids for a week. They're still learning and growing and not hustling to get money and stealing and checking out and possibly dying from fentanyl or other overdoses. Next slide. Do you have any questions for Ellie and I?
We do. There's actually been a couple come in over the chat line. Please feel free to continue to submit your questions there if you feel comfortable that way, or you can unmute yourself and ask directly. But first of all, from Jacqueline Murillo, are there any restrictions not mentioned here that would apply to using telehealth for the counseling component of methadone/MAT treatment or OTP NTPs?
Probably Ellie should answer that because she's explored the telehealth with mental health issues.
Yeah, so with the telehealth and the psychologists, we are not running into any issues. I know that there are different payers, right? And so we're an FQHC, we're primarily in rural areas, and we have primarily Medi-Cal patients. But I think the biggest issue for folks is depending on what area you're in and what type of service you're providing, the payers and reimbursement would be the issue you would run across. And so I know that the state of California is definitely much more progressive than many states, and the payers are much more flexible. So I think that payment would be more of the restriction than anything. As an FQHC, our mission is really just to care for those underserved. And so if we do run into any issues with payment, for us, you know, we try, of course, but for us, it's just making sure that payment gets the patient, gets the whole person care and treatment. Currently, we are able, as an FQHC and in those areas that our providers are doing the psychotherapy via telehealth, they have been billing and we've been getting reimbursement on that end. So for us, it's been working okay in most scenarios. I know there's definitely some denials and things like that that our billing department runs into, but I think that's the biggest restriction for the mental health and the counseling component. The other restriction that you guys on the line may be familiar with is the prescribing, and so it's not necessarily the counseling component, but the prescribing of the Suboxone. So if, for example, 6 months ago, let's say, Dr. Pierce had a patient and he never met them in person and only had done a telehealth visit, we would have run into some barriers based on the Ryan-Height Act. And so I know that we're waiting, I think by December, we should have that DEA like special registry where the providers will have more flexibility. But because we've been lucky enough that we have so many clinic sites and we can just have the provider go and have that first initial contact physical examination done with the patient in the clinic, all of the follow-ups being done telehealth are 100% in compliance, and so we're very comfortable on that end.
Thank you. Rhonda Weaver asks, will this recording be forwarded to those in attendance? The answer to that question is the slide deck will be sent to the folks that are in attendance, and the recording, once it's compiled, will be at raven.careinnovations.org/e-learning under the tab prior e-learning sessions. So in answer to the question, it won't be sent to you because it's a large file. It'll be available on the raven.careinnovations.org website. Alicia Lopez asks, she's very interested in hearing about the technology used for telehealth. Does it integrate with your EHR?
So the technology that we use, it's a software called Polycom, and it doesn't necessarily integrate with our EHR, but I think I should explain how our telehealth visits work. So a lot of folks are more familiar when you contract with a telehealth organization and they have outside providers, and they either would document in your system or they would, scan over a chart note to you, something like that. The way we do it in Borrego, we have so many different clinic locations that the patient comes into one of our clinics, so let's say Coachella, and then the provider is in one of our other Borrego clinics, for example, Dr. Pierce in San Jacinto. And so our team at the patient site documents the chief complaint, the PHQ-9, all of that already in the same EHR. The platform for the actual telehealth visit is really more like a video technology component than actually integrating anything with the EHR itself. Like, we take vitals in the clinic. And so I think in 2020, when we start, all of us in healthcare, exploring where the patient is at home, and using things like peripherals and blood pressures that get recorded and go into the EHR, that's something that we as an organization are looking for right now. And there's a lot of vendors out there that have different solutions. And so we're exploring that ourselves right now. For now, it's Polycom that we particularly use, and it's more a video platform than anything.
So what I do is I put my laptop in a position so that my face is looking good, and I'm kind of trying to look at the patient straight on rather than the patient looking at my profile. And then I'm typing and entering and looking at the urine drug screens on my AMR, and then I'm looking up at the patient and asking them questions. So we have two computers in the room. One may be a TV screen, one may be another laptop, in addition to the laptop I'm using for my EHR.
Great description, Dr. Pierce. Thank you. From Peter Marani, what's the appointment adherence rate for in-clinic visits versus telehealth sessions?
Do you have any statistics, Ellie?
I do, yeah. I think we can probably combined answer this, Dr. Pierce. You can probably answer for your patients and your feel for it, and I can give you guys some data. So our telehealth no-show rate has ranged between 12 and 18%, just depending on the month. And so organizationally, our goal is, of course, under 20%. I think we pretty much hover around the 15% range for our in-person visits. And then our telehealth no-show rates all across the board is about 18% at its highest. For Matt, I think our no-show rate with the telehealth follow-ups is a lot lower. Dr. Pierce, I don't know if you want to speak to your patients in particular and how you feel about that.
I'm thinking about 25%, and they also come, many times they arrive late. We want them there 20 minutes ahead of time to give us the urine drug screen test process done and get into a room, but they seem to come 15 minutes late, which sets us behind. So we just have to realize that and kind of plan with it.
Okay, thank you. Next question from Cheryl Buffo. Does the MA do the urine drug screen, and does the MAT provider have those results prior to the telehealth visit? It's I think in your last answer, Dr. Pierce, you mentioned that you want them there 20 minutes ahead of time. You want the urine available so that you have the results as a part of the visit.
Right. We're looking to see if they're taking the buprenorphine or not. If they're not taking it, they may be selling it. So we really need to see that. And we also have this really, really wonderful urinalysis that you tip it on its side and it checks it to see if they were adding bleach, if they're trying to neutralize it, if it's not warm, if it's not really urine. And then also it checks for like 5 or 6 different classifications, maybe 8 classes of drugs. So it's really wonderful. It has to be read in 5 to 8 minutes, so we really love it. But it seems to be very sensitive, so we may have to send something out sometimes to confirm things.
Okay. Stephen Gutierrez, does the patient need to physically be located at the clinic, or can they attend from home to meet telehealth regulations? Ellie, you mentioned that in passing in one of your comments that you're transitioning, but if you want to go ahead and talk to Stephen's question.
Yeah. So right now, the patient does need to be physically in one of our facilities that's licensed and in scope. So as an FQHC, we have like 26 of our facilities licensed and in scope. We're hoping, I know Medicare is kind of taking the lead, and there's been some information and bills going out that in 2020, we will hopefully be able to see patients at home. There is one exception right now, and it's if the patient is considered a homebound patient, that you can do a telehealth visit with the patient from home. We've not explored that area yet ourselves, but I know some other folks in healthcare are definitely exploring that. A lot of the commercial insurances are doing that.
Thank you. Cheryl Buffo again, do you just use telehealth for the MAT visit, or do your patients participate in group or individual behavioral health telehealth visits too?
So in our organization, we do telehealth for MAT. We do it for psychiatry, psychology. We've not done group visits. The groups that we've had have been in person. And we've also done it for transgender, HIV, Hep C, or all of our internal medicine providers, because they're spread thin as well. And so we have some primary care that's done via telehealth as well.
Thank you. Alicia Lopez asks, are your telehealth visits reimbursed through CMS?
As an FQHC, the majority of our patients are not Medicare. They're mainly Medi-Cal and managed Medi-Cal, and so the reimbursement is going through, our core wraparound rate as an FQHC. We have a little bit different structure. So there's some websites, like if you go on the California Telehealth resource, they have a really nice guide that will walk you through kind of a crosswalk of, depending on where the patient is, what type of facility you are, and who's going to bill. So for an FQ, we bill from the provider site, and we bill the state the same CPT code. And so as long as we're in that rural facility and rural area and we're meeting all the guidelines, they do reimbursement. I hope that answers your question.
I hope so too. Thank you. Have a question from a Dr. Ben Morrison. He's a former CMO at community medical centers. His question is, how do you interpret the 4 walls issue? Can your provider be located outside of a licensed clinic?
Very good question, doctor. You're putting me on the spot here. So I love actually that, because I love to kind of think outside the 4 walls, if you will. And so for us, we have actually not ventured into the area of the provider being from home. However, we've connected with a lot of our different resources, California Telehealth resource. And so the provider could technically be at home, for example. So there's some restrictions on some guidelines that tell you things like they can't be in a hotel, they can't be like out of the country. And so if, for example, you had a contract with your provider and they were at home and they virtually entered the four walls of the clinic, the patient, as long as the patient is physically today, the way the regulations are understood, as long as the patient is physically in the clinic, the provider technically can enter those four walls virtually. We have had issues with the technology, if you will, and kind of the video compression and what that would look like. The other thing to think about is if the provider is, depending on the way they're hired with your organization, if they're contracted, if they are full-time on internal hire and things like that, you have to look at different insurance coverages, FTC, GAP, things like that. So it gets tricky. It's something you can do, and many organizations who do contracts for telehealth specifically, the providers that they're giving you in your contract are actually most of the time located at home. So if you're looking at doing it with your internally hired providers, I think the trickier thing is setting up guidelines, restrictions for them on, where is an acceptable place to be, and kind of just, what that FTCA coverage looks like and things like that go.
But in addition to that, they need to give us a urine for the drug screen, and they need to pick up their medication. So we've had some patients come the next day to give us the urine drug screen because they have a problem with urinating on demand, and then they can pick up the medication once they pass that test. It's hard to do that from home is what I'm saying.
Understandable too. Thank you. Question from Jacqueline Murillo. Are you only using telehealth at your FQHCs or also at your methadone clinics?
We don't have methadone clinics. Methadone clinics have very high security and are a completely different game and need a government license, etc. Go ahead, Ellie.
Thank you.
I was just going to say, I think maybe that was a misunderstanding. Yeah, we're only FQHC clinic sites. We don't have a methadone clinic.
Thanks for the clarification. From Alicia Lopez. Go ahead, I'm sorry.
If I could comment, I think with methadone, you can keep taking more and more. You can take other drugs on top of it and get high or intoxicated, where with Suboxone, it has a ceiling. So that may be why the security and the laws are very different for Suboxone. We have them in a lockbox in a nurse's locked room, whereas a methadone clinic, is a very high security area with security guards and, cashier-like plexiglass protecting the nurses.
Thank you. Thank you, Ellie, for responding. There was a request from Alicia Lopez to send along the California Telehealth resource link, which Ellie has kindly done to everybody in the audience via the chat window. So that's out there. Other questions? Again, either put them in the chat box or feel free to unmute yourself so you can ask directly. Any other questions or areas that you'd like our two distinguished faculty members to address? Penny Larson asks, has this been video recorded? The answer to that is yes. The video will be up on the raven.careinnovations.org website as soon as it's compiled.
Oh, I see what she's asking. Sorry, I'm reading her question as it comes in. Is the video recorded for the appointment? And she says, why couldn't we just use Skype and say Athena? Okay, so to answer the first question, our video for the telehealth session is never recorded. And it's just a live session with the provider. So it would be sort of like Skype, right? Or FaceTime, for example. Our organization, we do just use our Polycom because it's something that we've had for years. But yes, there's a lot of organizations who are using things like Skype, or I think Teams on Microsoft is putting out some type of healthcare platform. And so myself and our CIO are exploring different software and different video platforms, but you don't need to use anything in particular as long as they're HIPAA compliant. I believe Skype has a HIPAA compliant platform. So I think the biggest thing that you would want to ask is to make sure that the software is video compliant, and that whatever system your provider is documenting, of course, would integrate with your EHR. I think that would be the best solution. Seems like the patient using FaceTime would be really helpful to them. Yes, so as FaceTime or Skype, or as long as your platform is HIPAA compliant, a lot of organizations are doing like white labeling with different apps, providers who would give a HIPAA compliant video app where you can go in, create the appointment, the patient can request it and do it off of their cell phone. Borrego has not been able to explore this yet, I think because of the regulations right now as they stand, since we're only able to bill for folks who are homebound. It's not something a lot of folks have explored other than some of the commercial insurances. But any of the telehealth organizations that are online, there's so many different software vendors, and you can just call them and ask for a demo. We've been doing that ourselves. We've had like 10 different demonstrations with different organizations. So depending on the software you use, some vendors are going to be more integrated and will be able to kind of push those appointments into your system for your providers to pick up. And the patient could use the application on their phone, and whatever FaceTime or Skype video source is linked to that software vendor.
Alicia Lopez asks, what is the approximate visit time?
Well, I've been using about half an hour, but usually it takes about 15 minutes or so to see a follow-up patient, because I'm not examining them, and it's basically history taking, looking at the urine and making sure the medication's there, double checking the number of pills or films we're giving them. But as far as the induction, we try to keep them there maybe an hour and a half to 2 hours, but I don't need all of that time scheduled with that patient. I have to be able to step out of other patient rooms, so we schedule it lightly around the induction time so that I can step out in case there's a problem, or just to double check them and make sure things are progressing well, and then give them the next small dose.
Very good, thank you.
Somebody mentioned homelessness there. Well, that's difficult to do. Where would they put their Suboxone or their methadone if they were homeless? So that's an issue. Well, maybe they're couch surfing, but then you can't always trust the friend of the week they're with to be secure about storing their medications.
Yeah, you know, Dr. Pierce, I have something to add to that. So one of our community partners had some experiences, not only with their patients who were homeless, but just patients who had trust issues. Maybe they were couch surfing, or they lived with their girlfriend and their cousin, and they felt like they couldn't have their Suboxone at home. And so that particular entity had a storage for their patients, and they would dispense they would keep it for them. And so the patient could come if they wanted every morning or once a week or whatever it was that they felt comfortable having. And the provider would actually store it for the patient and do like an inventory log. So if your organization is comfortable with that, I would say getting some type of double locked cabinet and creating an inventory system with your nurse that would be, I don't know that you could say dispense, right, but that where you would sign out and have a policy where this is how we held the medication for the patient.
Penny Larson's comment was, for my patients is still about their intent, even if their housing is not so stable.
Dr. Pierce, do you have any recommendations on that, or have you experienced that at all?
Can you be more specific? I'm having trouble finding a specific question there.
Penny, do you want to unmute yourself and open the conversation interactively?
Sure. I'm just saying that my patients, if they're intent on being sober, they're going to find a way to keep their meds secure. And it really doesn't have to do with their housing. I mean, actually, it's on their list of things to do, but sometimes the housing issue is so much harder to deal with just than anything else. So I'm just saying I don't see that as a real issue.
Good comment.
And like I said, many of my patients are, one step to literally being on the street, but they still manage to keep their meds secure, and they bring the wrappers back. And, like I said, I think it's more about intent. Are they intent on staying with the program, or are they not?
Mm-hmm. Great point, Penny. Thank you. Other questions or issues that the audience would like to bring up? We currently have a few minutes left. Well, I would really like to thank Dr. Pierce and Ellie for taking their time today and sharing the Borrego experience with us. I think there were a number of great points that have been raised by the group as well as by our faculty. And hopefully everybody will benefit from this. Just had another comment come in from Dr. Morrison as far as choosing locations for the visit. Is it put as the patient's location and not the provider's location? I'm sure that's from a billing operations standpoint, Ellie.
Yeah, and so as an FQHC right now, because our patient is in the clinic and our provider is in a clinic, we can choose either the patient site or the provider site. Typically, I think that the patient site is simple from the perspective of scheduling on certain EHRs. And so our current EHR, it's the software is provider-centered scheduling, and so it makes more sense from the provider end. And so since we have that flexibility, that's how we bill. When you get to a point where the patient is at home, that's also going to make a difference. And so depending on the regulations, I think you just want to have either a decision tree for your staff to understand if you're going to have a patient at home, how they're going to bill. And then the one important thing is making sure that they're consistent. So across all sites, you choose one way or the other. I don't know the regulations that might change in 2020, but for right now, that's what we've been told. We just need to make sure we're consistent, and our organization has chosen the provider site for the billing purpose.
Penny Larson, is HIPAA an issue? Because it seems to me that TH is iffy in many ways.
Telehealth, probably.
Telehealth, yeah.
Yeah. So I went to a telehealth conference the other day, and there was a whole speaker, and he was very technical. But I would defer to your risk and your like CIO, for example. But they had an entire session with a lot of technical words on cybersecurity and how to make sure you were HIPAA compliant and what platforms you were using and where you were documenting. A lot of the presentation that they had was surrounding when you were having outside folks coming into your system. And so because Borrego to date has not really contracted outside and used different platforms, and it's all in-house, we haven't run across too many concerns on the security issues, especially because we're using the Polycom. And it's, in our case, our IT department routes one connection to the other, and they're very secured connections. But when folks are using outside connections, so for example, if Dr. Pierce were at home and he were using his laptop at home, that's when you come into some security issues, and you want to make sure to work with your IT team. So I am BFFs with our CIO now.
Other questions or issues that the group would like to bring to our faculty? Well, since it is Friday afternoon, Summer Pen, did you mention you have Polycom configured on your iPads to conduct these visits? I think you're using it as a freestanding communications platform, that it's not necessarily connected through an iPad. It's really an X25 platform, isn't it, Ellie?
You know, I'm not familiar with the terminology X25. So we have two different hardwares. We have the like a Polycom cart, for example, and that was something that was purchased as a whole unit. And then we also have the Polycom connection on laptops, and so we can just buy like an HP laptop or something. We've not used iPads yet, but I've talked to our IT team about it. It's something that could possibly be compatible. I think some softwares are more compatible with iPad. And so it's just not something we're using yet. Their providers mainly use laptop, and then when we have the patient end, the patient usually is on the end with the actual Polycom cart itself.
Summer passes along. We had issues trying on our iPads, so would love to connect if you're able to get that successful. So Summer, Ellie, you need to keep everybody's email address in their back pocket.
Perfect.
Well, let me be the first to send my personal thanks to Dr. Pierce and Ellie for spending their time with us today. I think they've been super outstanding, and I appreciate everybody's questions and lively discussion after their presentation. If there's one last or two last questions or concerns people would like to bring up, that would be great. Otherwise, I'm wishing everybody a happy Friday afternoon and a wonderful weekend coming up. Thank you all so very much.
Thanks, Ray. You too.
Goodbye. Thank you.
Thank you, everybody.